our experience with malaria. Malaria as a disease that we have seen for the past 2-3 decades. And I'll share some of my experience with all of you. Now, this vaccine has come in at the right time and it's becoming one of the tools for managing or for preventing malaria. And when we talk about malaria, as I present to you, you would find out that in this presentation, I will give you a short introduction. I'll look at malaria pathogenesis, some historical perspective from my experience as a young doctor on the ward to the current state that I present myself as one of the key players of the RTS vaccine. The RTS pilot implementation that was sponsored by the WHO. What the country right. What the country is currently doing to make sure that this vaccine reaches every child who is at risk of developing severe or complicated malaria. It's a major killer, and it's been one of the diseases that when I was a young house officer, on a daily admissions day, you would have about 15 to 20 children reporting with complicated malaria. And out of these, we would have a significant number not returning home, because at that time, the tools for diagnosis, the tools for managing were not available. Fast forward, this disease, on a daily basis, you would not find a case of malaria on our emergency unit. So 20 years ago, when we were finding about 15 to 20 admissions on a daily basis, we are not getting. The P. falciparum, the most interesting of all the parasites, that's all the life stages of the red blood cells. And the response that leads to the complications that we see from the disease that we're going to talk about. What is reaction? The release of cytokines and inflammatory conditions makes these children unable to cope. Unfortunately, we're losing some of them. In 2004, the Lancet published a series asking the question, why and where are 10 million children dying? And in this document, you will realize that there were some countries that were contributing to the high mortality rate that we see in Sub-Saharan Africa. Further to this document was how can these deaths be prevented? These deaths were from malaria, pneumonia, diarrhea diseases, HIV, and underlining this was malnutrition. Currently, there are vaccines for pneumonia. Currently, there are vaccines for diarrhea diseases. And so we have seen a remarkable reduction in diarrhea diseases as well as pneumonia and meningitis on our wards. But until the introduction of the RTS vaccine, malaria was still one of the leading causes of morbidity and mortality that we see. I've mentioned that as a house officer, we used to see a lot of cases, but currently the narrative is changing. It's changing to the extent that on our pediatric wards, when we used to see about 5 to 6 deaths on a daily basis, in current epidemiology, we are not seeing deaths in children on our wards. These phenomena, we believe that with the addition of more tools, we should be able to prevent and let more children survive. Now, we are very much aware of this. And what we know is the fact that the malaria itself, clinical signs emerges when there's a rupture of the red cells after they've grown inside the parasites. In one of our studies in the Barikuma area, we found out that nearly about 30% of the children has asymptomatic malaria. And so As their cells are rupturing, they are developing anemia to a point in time when they develop the full-blown malaria. If they do not get into the hospital, they die from severe anemia. The genesis. This it's a normal red cell, and this is an infected red cell. The infected red cells have that tendency to attract the non-infected red cells, and when it gets to this stage, they are destroyed. It causes clamping. In there are platelets, so they cause thrombocytopenia. They cause cytoadherence, and in the brain to lead to cerebral malaria. Central malaria and low infant death, stillbirth, low birth weight are some of the complications that we see. And then the major killer, cerebral malaria. That's where. So if you look at pallor, anemia, this child, if you look at the conjunctiva, it's white. And in our clinical practice, we call it paper white. If you do not transfuse this child and give the appropriate anti-malaria, you are likely to get. See that this child was likely to be having asymptomatic anemia, malaria. So on a daily basis, hemolyzing. So the major event strikes and will come with HB, so 1.2 grams per deciliter. Very important. Again, the disease can cause the red cells to hemolyze, such that you pass urine that looks like Coca-Cola. And passing the Coca-Cola urine, it is very obvious to the parents. So they come to the consulting room, and their first expression to the doctor is that the appearance of my child's urine is not good at all. At this stage, if you do not manage this child well, the hemoglobinuria will destroy the kidneys, causing acute kidney injury. In jaundice, we are in a region where sickle cell disease is about 2% of the population, in addition to glucose-6-phosphate deficiency. In the presence of sickle cell disease and disease PD, they tend to develop this level of jaundice, anemia, blood transfusion. The impact of the parasite on the central nervous system is such that for this child, had attained several developmental milestones, crawling, doing everything. At this stage of cerebral malaria, he's lost almost all developmental milestones. And the impact of this disease on CNS development is also very high. We've seen cases where, from our Malaria team, whereby they've done CT scan, MRI to find out the causes of death. And the raised intracranial pressure that occurs leads to herniation. At that point, when there's respiratory arrest, you will resuscitate this child. This is showing hemorrhages in a patient with cerebral malaria. And so it's a disease that actually has very significant pathological changes within the brain as the children present. You've seen ocular changes within the eye. When you do ocular findings of this nature, the probability that the child will die is very high. It has a very direct relationship with the probability of surviving your cerebral malaria. We have now known that malaria is a multi-organ disease affecting the lungs, the gastrointestinal system, the heart, the central nervous system, the hepatobiliary system, the liver, and the renal system. And so in our current teaching, we teach the multi-organ component of the disease so that you get it right and be able to save the child. Now, there are different tools for managing or for preventing malaria. Bed net, residual spraying, both indoors and outdoors. The addition of artemisinin combination therapies are all some of the tools for managing and reducing the burden of the disease. But if you look at the number of cases across Sub-Saharan Africa, there was still the need to have additional tools, and the RTSs came in. RTSs had gone through a very long developmental phase, right from 1984 at the Water Reed, when the vaccine was developed. Fast forward, had gone through several stages to the first exposure in Gambia in adults. And after that successful trial, there was the need to push the vaccine to children. And so 7 countries, 11 clinical sites. In Ghana, 2 sites were involved. Now, what is the vaccine like? It's a combination of the R and T regions of the circumsporozoids that has been fused with the hepatitis B surface antigen, and further fused with the antigen with the adjuvants. So the RTSS, the 2 SS are components of the hepatitis B surface antigen, and the RT are from the circumsporozoid component of the parasites. And the AS01 adjuvant emulsified around it and being used for this vaccine. In Sub-Saharan Africa, areas of high density, moderate to high densities, were thought to be these areas where the vaccine would have a significant impact. So we have Burkina Faso, Ghana, Gabon, Kenya, Tanzania, and Mozambique. All these countries participated in it. And as I said, we needed to pick countries that had high transmission. And in all these countries where we did the vaccines, bed net use was also very high. So even though bed net was being applied, there was still a high burden of the disease in these countries that participated in. Developed by GSK, first human exposure in Water Reed, first African exposure in the Gambia, childhood exposure in 7 African countries, and about 15,000 children were randomized to receive either the vaccine or the controls. It was highly regulated by all the institutional review boards in all the countries, by FDA, USA, and by EMEA, the European medicines. And it took about 2 years to go through all the approval processes before this vaccine could get into the children. A little bit about the science. So, before the vaccine was started in the phase 3, there were phase 2 studies that were looking at younger children, 6 weeks to 12 weeks versus 5 months to 17 months old children. Interestingly, it was found out that the vaccine response was not that good for the younger children, rather for 5 months and above. And so the studies, earlier studies, the phase 2 studies selected 5 months above children to receive the vaccine. The placebo was a tough one because if you have a vaccine that you believe would work, why do you give the child a placebo and the activities around it was very, and so it was found out that, okay, in Sub-Saharan Africa, rabies was also one of the diseases that can kill. And so the placebo used in this study was the rabies vaccine. That's why it was in a 1:1 randomization booster doses were given along the line. Now, the vaccine demonstrated a cumulative efficacy of 50% against clinical malaria, reduction in 30% severe malaria, reduction in hospitalization in 21%. Now, these figures are very important from the public health point of view, looking at the number of children in Sub-Saharan Africa who are at risk of developing all the complications that I've shown on a daily basis. If you have a vaccine that will reduce 30% severe complications, if you have a vaccine that will reduce 21% hospitalizations, it's going to have a significant impact on the hospital systems. And therefore, WHO felt that how can this vaccine be used? But before that, other things that were checked were the reactogenicity, the severe adverse events were found very comparable. Fatal cases, meningitis initially was felt to be imbalanced to the RTSS arm. However, further studies revealed that those were just a chance findings. Now, the WHO then decided that in all this, how can this vaccine be implemented in Sub-Saharan Africa? So selected Ghana, Kenya, and Malawi to do what we call the pilot implementation of the vaccine. To answer three questions: how would institutions incorporate this into their health system? Two, are there any other safety signals that the phase 3 could they pick? And also evaluate the impact. This has been done successfully, published in the Lancet, to find out that countries in Sub-Saharan Africa can actually implement and add it on to their immunization programs. And it is currently ongoing. What is happening in Ghana? In Ghana, there are 261 local metropolitan, municipal, and district assemblies. RTSS is being given in 93 districts. And there's one other vaccine on the block, the R21, that just at the time when WHO approved the RTSS, the R21 group had also completed their processes without, and so both vaccines are currently in Sub-Saharan Africa and in Ghana. It's being given. So R21 in 43 districts, RTSS in 93 districts, a total of 136 districts. So we are almost there in giving the vaccines to children 5 months and above for 4 doses to prevent malaria. And we believe that this vaccine has led to our observations where on a daily basis, the whole month, we are not getting the case of malaria, RDT positive or microscopic positive, and children are not dying from malaria. Yes. Particularly in the hospital where I work, the scenario may be a little bit different as you move to the rural and other areas where resources are limited. But at the tertiary level, we've seen a dramatic change in malaria presentation and mortality. Right, so I've made mention of this already. It's been recommended in very high areas. So you realize that the 136 districts are districts with a high level of transmission, moderate to high transmission. At the same time, bed nets are being given. The seasonal malaria control program is being post-discharge chemoprophylaxis, and the WHO policy of test, treat, and track, in a sense that to avoid drug resistance to the artesunate, indiscriminate management of malaria that you have not confirmed. It's waste of resources, potential for incomplete treatment, potential for drug resistance development. And so the fourth factor here, test, treat, and track. For every child who comes to you, you have to test, then you treat, and make sure that the child is completely treated. And therefore, the malaria control program changed its name to Malaria Elimination Program in Ghana, because the burden of the disease is gradually going down. And so now they have even stepped up their effort to say that rather than we controlling malaria, let us eliminate malaria. And bed are continuously being distributed. There's this factor here, better healthcare access. The health insurance policy has led to access. The health system is improved. Diagnostic support materials are currently available. Therefore, when you have all this plus malaria vaccine, you're likely going to make an impact. I've mentioned about the fact that 15 to 20 children admitted on a daily basis 15 to 20 years ago, 10 to 20% of them will die. But currently, we are not seeing that in Confederate Teaching Hospital. A dramatic reduction in our mortality. And I would want to remark on this all the way I go, because what we saw as house officers is different from what our current house officers are seeing. And therefore, the tools that we have in place are making impact. We've had a collaboration with University of Utah for the past 20 years. And in one of the communities that we work, we have a population of about 22,000. And several research, and one of the key research that we did was childhood mortality, particularly. In 2011, the peak of the malaria epidemic, we noticed that children were dying at home. There were several factors are responsible for this. Lack of knowledge, underestimating of the conditions, access to healthcare. And in our publication on this, verbal autopsies and analysis of common causes of childhood death in the Bangalore sub-district made us to respond to do further research almost every year, take students into the communities, educate them all the time when we go into the communities to bring the awareness. And we believe that our interaction within the community had made an impact in terms of lifestyle, in terms of their attention to healthcare, and things that it is that they need. We found out that malaria, pneumonia, and meningitis was responsible, malnutrition being the underlying factor. And in that study that we did, where we had 35 to 40% of the children had asymptomatic malaria, it was very revealing, because if you have children with asymptomatic malaria, it means that that child had HB around 6, 7. So the next episode of severe malaria, the HB drops to 7 or 3, and will not get into the hospital to get blood transfusion. So some of the interventions, we supported community clinics, strengthening the health systems, bed nets, the Health to Go program, the program expansion in other parts of the country, and strengthening of the expanded program of immunization are some of the things that we encourage the communities to do. The current system that is being run, the director is here, is to make sure community health nurses are available within the rural communities to be able to educate. Because even when you take the vaccines to them and you do not educate them, the only one case of malaria that may drop and they do not report appropriately, we may have a mortality out of that. So community education is very important, and we always do that with our. In conclusion, I thank you all for coming, and then we say that the current tools that we are using, bed nets, RTS vaccine, R21 vaccines, are likely to reduce the impact of malaria, and Ghana is likely to have elimination if all efforts are put in place. Thank you very much.
Well, what are the cutting edge research questions that you are working on, or that you see as the field needs to address in the next 5 years on malaria?
So we have found out that the epidemiology is changing. We've seen older children coming with complicated malaria, malaria with acute kidney injury, malaria with respiratory complications. Now, the current research we are doing with acute kidney injury from severe malaria is the role of paracetamol. We found out that a higher dose of acetaminophen is likely to correct the acute kidney injury that is associated with complicated malaria. The cerebral malaria, the use of levetiracetam as an anticonvulsant is being considered because it is thought that even though the child may have had convulsions and is unconscious, if you control the central nervous system seizures, you are likely to have the child emerge with no neurological complications. So we are about to start studies on cerebral malaria and acute kidney injury, and specifically the use of paracetamol, a double dose of paracetamol in children. The other research question was with the anemia. Obviously, when the child comes with anemia, we would want to give either packed cell or whole blood. It takes some time to get the packed cells. The resources to get the packed cells are not that easy. So the research question that is on the table that we are working on is, would packed cells versus whole blood give the same findings? So these are the 3 areas that we are looking into.
Questions? For the diagnostics, so you mentioned the 3 T's, test, treats, or test.
Track.
Yeah. When somebody comes to clinic or they're in the community, the testing, is it free or they have to pay for it? And what's the turnaround time for you to get the results? Is it straight in clinic, or you reach out to them later on once you get the results to then effect treatment?
Can you repeat the question for the virtual audience?
So wanting to find out the diagnostics of malaria. So prompt treatment of malaria is essential. It is the way to go. Currently, the tool for diagnosis, the RDT, the rapid diagnostic test kit, 15 to 20 minutes, you have your results. And so, and it's widely distributed across the country. And because the National Malaria Control Program or Elimination Program is documenting how many of the RDTs were negative, how many were positive. And so you test and it's negative, you are encouraged not to give anti-malaria. Find other cause of the disease, of the illness of the child.
And if I remember right, there was the life cycle. There's always the hepatic phase where the parasite hides for a while. And the issue is, until it spills over into the blood, your RDTs or your peripheral bloods may be negative. So I believe the RDTs being available, which is antigen antibody, goes a long way, because to detect those who are hiding in the liver.
And you notice that the microscopy, it's small scale demand as well as the resource for microscope within the NP. It's not widely distributed across the country. So RDT is actually helping us address the problem.
What's the schedule for the vaccine? I know you could give 4 doses, but what's the interval?
4 weeks interval.
4 weeks.
4 weeks interval.
And in terms of how long do the antibodies last? Because now you're seeing it in older kids. Is that a limited duration?
So there's a waning, and so there's a booster, the 5th dose that is being given to the children. The issue about, you see, when you have the vaccine, the child 5 months to 17 months, they are now older, and so the mother's attitude towards vaccination is a little bit not very good. But the campaign now is that once you receive it, receive your first 3 doses, receive the 4th dose, and then your booster. And the current road to health chart, the booklet, has now been modified to have areas for RTSS or R21 to be documented. So in any child that has missed opportunity, you would be able to pick it out and then give it as the community nurses go around to find out those who have received and those who haven't received it.
Any breakthrough disease? Vaccines only prevent the majority, but then who gets breakthrough disease, and can you predict?
Most likely, but you realize that, as you said, during the vaccine trial, all the children in all the arms were given bed nets. It's one of the tools to prevent the disease. So, and as well as once you have fever, you have any condition suspicious of malaria, test, treat. So that is how it is. It's not like you are unlikely to get malaria, but once you get the malaria, we need to identify you first and manage it.
It's a very basic question, a surgeon question. What's the prevalence of malaria in Ghana? My impression is everyone gets it several times during their lifetime.
Yeah, so it's changing. It's changing depending on where you are. If you are in areas with high transmission, and coming from the pediatric point of view, in a year, in high transmission areas, about 2 to 3 episodes in a year. But in adults, if you've been in the endemic area for a long time, you're likely to get malaria within a year.
And is it much more virulent in children as opposed to adults?
Yes. Yes. So that the children less than 5 years, pregnant women, those are the target population that are highly at risk from the P. falciparum malaria.
Dr. Ansong, a bit of a different kind of question. What would be the cost of immunizing of a general immunization in the population with this vaccine?
The cost per vaccine.
The cost per vaccine would be.
Yeah, so the cost per vaccine is between $2 to $6 per vaccination.
So it would imply just an increase of 2% on the healthcare expenditure in Ghana, if that it would be the total population, correct? Okay, so it can be incorporated easily into the national health accounts without too much burden.
Yes. Okay. In fact, I'm told that by the end of the year, all the 261 districts would have the vaccine.
Is that a subsidized cost or?
Yes.
Subsidized cost.
In fact, during the production and the clinical trial, GSK was required to reduce the costs. Gavi was to support the vaccine deployment and the cost, and so there have been several cuts. It's very difficult for me to give the accurate figure.
I get it. Thank you.
Are there plans to produce the vaccines locally? Locally.
Yeah, so I think COVID-19 gave an opportunity for Ghana to establish a vaccine institute, and that potential is there to be able to produce RTSS vaccine in Ghana if the proprietary and all those details are given.
Is vaccine hesitancy a big problem in parts of Ghana?
No.
No?
No. It's vaccine.
Like here, is it?
Still trusts healthcare workers in Ghana.
Yeah. You see what some of us saw as house officers, as medical officers, and how mothers had gone through this phase of malaria in Sub-Saharan Africa. If you tell them that this vaccine will reduce your child's 30% likely, they are likely to receive it. Hesitancy is very low.
What do we know about the durability of the vaccine in childhood as we see Ghana in this transition from endemicity to hopefully moving towards eradication? As we transition, as kids grow, adolescents and adults, the durability as people are continuously exposed and then that exposure begins to wane, natural tolerance. What do we know about the durability? How long the immunity tolerance lasts?
Yeah, so you realize that these are some of the research questions that will further be ongoing until we have, for instance, 10 years of exposure in our population to be able to say, okay, currently those who have received the vaccine at the age of 5 months to 17 months, the next 5 years, the next 10 years, what it is that we have. The follow-up in the phase 3 was not that long. And if we want a 10 years of review or 15 years to be able to see how the vaccine works, there will be the need to do that.
Dr. Ansong, we have a question online. How are the plans impacted with the reduction or removal of UG funding that supports the vaccine procurement and rollout? I'm not familiar with UG funding. Anyone else?
Maybe USAID. US government.
Okay.
USAID.
Okay. Official Development Assistance, US government. Thank you. Okay.
Okay. So the National Malaria Control Program and the Gavi support for the vaccine didn't have significant sources from the USAID. And so I think they are still good to go for now in terms of the deployment. I'm aware that there are several programs in Sub-Saharan Africa and in Ghana that some of these changes have had an impact on, especially the HIV programs. But for the RTSS program, we are still good to go.
Do you anticipate any change in the clinical presentations in these kids now? Because you used to see a lot of cerebral malaria, but are they coming with a milder form, a different version, less more anemia, less more respiratory problems?
The change that we have seen is the acute kidney injury. Because in recent times, we've had about 4 children on the ward, they all come in with acute kidney injury from complicated malaria.
Vaccinated or unvaccinated?
Unvaccinated, of older children. And interestingly, the study that we're going to do, where we're going to increase the dose of paracetamol or acetaminophen to see response. In our tertiary hospital, we have the renal unit that does peritoneal dialysis. And so all the children who comes with acute kidney injury, they are put on peritoneal dialysis and they all respond. And these are some of the things that I would say 15 years ago, 16 years, 20 years ago, we would lose all these children because we did not have the opportunity to do peritoneal dialysis on these children.
And I guess maybe because in the air 20 years ago, you were inundated with a lot of young kids.
Sure.
We prevented all those diseases now. Those kids, I mean, the older kids were getting it, but I think because you don't see this one now, these are measures, the major players now.
I agree.
Any other vaccines coming on the horizon?
For malaria, Not that I'm aware of, but currently I know in Ghana we have the R21 and the RTSS.
Well, Dr. Ansong, thank you very much for joining us here today in Salt Lake City. I wanted to put in a plug for rapid diagnostic tests for malaria. Remember, about 8 years ago, we did that study. These are, what are they? Lateral immunochromatographic transfer assays, and they cost pennies on the US dollar. We compared a histidine rich protein type 2 assay with PCR and shown that it was nearly as sensitive and specific as PCR. We had no false negatives. We did have a handful of children that tested positive by RDT, negative by PCR, that had been treated with an effective artemisinin combination therapy within the last 30 days. So there appears to be some persistent antigenemia, but to be able to diagnose malaria, falciparum malaria, anywhere for a few cents and a very quick period of time with simply a drop of blood has really been a godsend for malaria control along with ACT. So if you're not aware of malaria RDTs, check it out. They're really, really helpful. I want to thank Dr. Rockwell, the interim director here for the Center for Global Surgery, for inviting Daniel Ansong and our team here today. And for everyone at home online, thank you very much for your support.